Good morning, everyone. So I'll be discussing 4 abstracts over here today. The 2 of them are in the neoadjuvant setting, 2 are in the adjuvant setting. The first one is the Helen 006 study from China. It is a multicentric randomized phase 3 trial done across 6 centers in China, and it studied de-escalated neoadjuvant protocol of weekly nab-paclitaxel, trastuzumab, pertuzumab as against their standard of care TCHP protocol in HER2-positive early breast cancer patients. So patients were randomized in a 1:1 manner, and this one stratification was on the basis of tumor stage, nodal stage, and hormone receptor status. The primary endpoint of the study was pathological complete response, and secondary endpoints were EFS, DFS, and safety. The study arm received nab-paclitaxel day 1, day 15 at 125 milligram per meter square with concurrent trastuzumab and pertuzumab at standard doses, and the standard arm received the standard TCHP protocol. So 689 patients were enrolled, 340, 345 in both the arms, and 330 patients were evaluated at the end of the treatment. So both the study groups were well balanced in terms of the T stage, the nodal stage. The incidence of hormone positive patients was also 60% in both the groups. So well balanced study groups. The study was conducted from September 2020 to March 23. The median age, so at a median follow-up of 26 months, this study was published, the data was evaluated and published. Coming to the main point, the pathological complete responses were seen in 66% of the patients in the THP arm, nab-paclitaxel trastuzumab arm, as compared to the 57% in the TCHP arm. And this difference was found to be not only non-inferior but to be superior in this particular study. This was clinically significant. Statistically significant. The PAT-CRs were seen in as I mentioned, in 66% of the patients in the THP arm as compared to 57% in the TCHP. In the hormone receptor negative subgroup, the difference was even wider, 86% versus 70%, while it was just 4% in the hormone receptor positive group. The differences, the forest plot shows that the THP arm did better even in the node positive subgroup of patients. Coming to the toxicity, the grade 3-4 toxicities were seen less frequently as expected in the nab-paclitaxel arm. So 13% of the patients developed grade 3 neurotoxicity in a neuropathy in the patient in the THP arm. The diarrhea and nausea were much more frequent in the TCHP as expected. So a much more tolerable regimen. So to conclude, we have an option, we have a regimen which is less toxic, easier to administer, and giving better pathological complete responses. Limitation, yes, we do not yet have the EFS and DFS data, so that needs to be looked into as in the coming year or two. So, but then we have a good option of THP as compared to TCHP or ACTHP even in node positive, HER2 positive early breast cancer patients in the NSCT setting. The next abstract is from MSKCC. It is this is a retrospective study of invasive disease-free survival and brain metastasis rates in patients who have received the optimal neoadjuvant treatment, neoadjuvant systemic treatment with chemo plus trastuzumab and pertuzumab. So this is, as I mentioned, it's a retrospective observational single center study from MSKCC, which aimed to analyze the IDFS and brain metastasis in HER2 positive EBC patients in the current era. And it also looked into the incidence of patients who have a HER2 negative residual disease at the end of their treatments. So 594 patients were included in this analysis who were treated from January 2019 to January 2022, and they have 75% of the patients had received ACTHP and 12% had received TCHP, while THP was given in 10%. So very good neoadjuvant systemic treatments were given. 55% had achieved a pathological complete response, 45% had residual disease, matching with the trial data. 36% of the patient who had residual disease had a HER2 negative residual disease. So this is one significant finding from this trial. Adjuvant treatment was given as per the standard of care. Coming to the IDFS, 3% of the patients at the end of 2 years had relapses, recurrences, 5.2% in the residual disease group as compared to 2.5% in the PAT-CR arm. This difference was statistically significant, again suggesting a correlation between PAT-CR and IDFS. Brain metastasis happened in 1.2% in the PAT-CR group as well as and 2.8% in the HER2 positive residual disease cohort. There were no brain metastasis in the HER2 negative residual disease cohort. The study just highlights that yes, we need there is a scope further for improvement in the neoadjuvant as well as adjuvant treatments in this setting. Coming to the adjuvant studies, the third interim overall survival analysis of the affinity trial at 8 years has been published the last year. And we all know affinity studied the adjuvant use of pertuzumab versus placebo in HER2 positive early breast cancer patients. So even though there was a disease-free survival benefit of 5%, 5.5% in patients who are HER2 positive, node positive disease, there was no overall survival benefit in the affinity study with addition of pertuzumab in the adjuvant setting in HER2 positive breast cancer patients. Whether it be node positive or it be node negative patients, there was no overall survival benefit. The curves have been sticking to each other till the end. So no OS benefit is the takeaway from this particular paper. Coming to the last, the ATTEMPT study's 5-year results. So ATTEMPT is a study where adjuvant trastuzumab emtansine was administered to patients with stage 1 HER2 positive breast cancer patients. And in this study, this was a phase 2 trial where patients were randomized in a 3:1 manner to receive either TDM1 for 1 year versus paclitaxel trastuzumab followed by trastuzumab maintenance for 1 year. And the co-primary objectives of this particular study were to look for the toxicities and IDFS. And also they attempted to look for the role of HER2-DX genomic tool as an predictive and prognostic marker for outcomes in this particular set of patients. So 512 patients were recruited, 384 received the TDM1 and 128 received the trastuzumab paclitaxel regimen. At a median follow-up of 5.8 years, the 5-year disease-free survival in the TDM1 arm was 97%. So quite impressive, very impressive data. As compared to that, the 5-year disease-free survival in the paclitaxel trastuzumab cohort was 91%. There cannot be a direct comparison because the study wasn't powered to do this, but numerically we can see there was a 6 to 7% benefit of giving TDM1. So that's all that we can derive from this particular data over here. Coming to the HER2-DX risk scoring system, a genomic tool which can be used over here on the tissue. So the HER2-DX low risk versus high risk, the disease-free survival difference was quite significant, 96% versus 81%. So in the times to come, the HER2-DX genomic assay may be used, or it needs more validation to look into whether it can become a predictive or prognostic marker or even a predictive marker to decide on better or optimize the adjuvant treatments. So that's the takeaway from this particular study's 5-year update. With that, I thank you for your patient attention. Thank you.